Ladies and gentlemen, hello, welcome to Compass, welcome to Quotidiano TV, to our today's podcast about microclots and long COVID. I have a very special guest tonight, Professor Pretorius from Stellenbosch. Professor Pretorius, welcome to Compass. How are you doing?
Hello, everyone. I'm doing very well. Thank you for the interview.
Really, I appreciate it a lot. You had a long journey yesterday, so that's really an honor that you've accepted with all this stressful time participating in this discussion. Ladies and gentlemen, I'd like first of all to introduce Professor Pretorius. You're the head of the Department of Physiological Science at the Faculty of Science in Stellenbosch, at the Stellenbosch University in South Africa. Several of your articles recently have been quoted worldwide because of your research related to long COVID. Please tell us something about your research.
Thank you very much for the kind invitation to tell you something about what we've been doing. So we have been looking at acute COVID as well as long COVID for the past few years, but the journey started a very long time ago, probably 2004, when I started looking at thrombotic disease and thrombosis and stroke and Parkinson's, Alzheimer's, or inflammatory conditions that might have some component of inflammatory disease related to circulation and to blood, and that cause changes to the blood profiles, the systemic blood profiles in these diseases. So the work that we've been focusing on, both acute COVID and long COVID, then was it was an automatic process of when acute COVID, the pandemic started, we decided to get some blood from patients and look at the blood samples. We found significant clotting pathology, including platelets, which are small round entities that is well known to be part of clotting. And then when the first reports of long COVID were noted globally, it was quite easy for us then to also just find patients in South Africa with long COVID. And that's how the journey started, from a very long time ago with no COVID present until recently when acute COVID then became an issue. And luckily we could find patients that was in the ICU of some of our clinical collaborators. So that's how the journey with acute COVID and then eventually long COVID happened.
Yeah, recently in Nature, there was an article about you. I mean, that's a great honor for a scientist to be quoted by Nature, isn't it? Called "Could Tiny Blood Clots Cause Long COVID? Puzzling Symptoms." And now regarding the history of your research related to COVID, in August 2021, you co-authored your first paper to raise the microclot theory. So still you're not ruling out other explanations or a combination of them, if I'm not mistaken. In fact, you believe that the leading hypotheses about long COVID causes are interconnected. Could you tell us something, please, about this interconnection?
Absolutely. There currently have been a few hypotheses that have been put forward by various global leaders in the field of acute COVID, long COVID, and then many other people joining forces to look at what's happening in long COVID. So the hypotheses currently basically say that microclots, one of them, is central in long COVID, but then also some of the other hypotheses include antibodies or then autoantibodies. And the third main hypothesis is viral persistence, where the virus goes and hides and then sheds spike protein into circulation that might cause some of the long-term damage that we see in various organ systems. So with our collaborators, global collaborators, which are probably around about 60, 70, that we all meet in regular meetings at various times per week and per month, we join up and look at it. We believe that there is not a one prevailing hypothesis. We believe that everything plays into each other works together where, for example, viral persistence with spike protein being shed might drive microclot formation that results in widespread thrombotic endothelitis or inflammatory reactions of the whole vasculature, and that in turn might trigger antibodies and eventually autoantibodies. Now, that said, the three prevailing hypotheses then culminate into widespread organ damage, and we believe with the microclot hypothesis that that might be due to the fact that these tiny microclots and vasculature that are so inflamed prevent oxygen transfer to many, many areas of the body, from the brain to any of the organ system to the muscle, and that might be related to the numerous symptoms that we see. But that in mind, that could be driven by viral persistence if it persists over months, and eventually we think that autoantibodies and antibody reaction will happen. So the three hypotheses might not be happening simultaneously, particularly the autoantibody reaction, but we do believe that the microclot and thrombotic endothelitis are quite central early on in the disease.
At which extent did the way you investigated microclots differ to what other scientists had observed till then? Because you went further.
Yes, so many scientists looked at, for example, samples from people who have died. They looked at the lungs and they found clotting pathologies. So right in the beginning, scientists believed this was just another pneumonia, viral pneumonia. And I think that was the prevailing thoughts within the first few months of the condition. Then it came to light the longer people started looking at various samples of various autopsy results. They found that there was also clotting pathology, where there were these significant clots in the body at various places. So for us, it was right from the beginning. We thought, and we described it, I think, in the May of the first part of the pandemic, 2020 already. We said that this is not a pneumonia. This is a thrombosis-related disease, looking at clotting. So I think it was very clear to us then in a few months after that we were spot on, and it is in fact acute COVID, and then moving into the persistent symptoms of long COVID is indeed nothing else but a severe clotting disease, not a viral pneumonia as it was initially thought to be.
So that was something new. How did other collaborators or scientists react once they read your paper?
I think in the beginning it was an interesting concept. They were not sure whether it was true or not, but I think very early on there were key researchers from key universities globally that said the same thing, and then it was just like a roller coaster. And that was also the title of our first review, COVID-19 disease as a roller coaster disease, where it first started as a clotting pathology, and then all the clotting processes are depleted, and then the person go into bleeding. And right in the beginning, some people actually thought it was actually a bleeding disease. But we thought from the beginning that it started off as a clotting disease, and then when all of the clotting factors are depleted, then you do not have any clotting anymore, clotting molecules anymore, and then it goes into bleeding. And clinicians saw that in the beginning, where if they left patients without treatment, they would eventually die of bleeding. So this was this roller coaster of events from one part of clotting to another part of clotting, and that is in the acute phase. So yes, so I think it was accepted quite early then, when more papers came out to actually show that there were a clotting component involved in acute COVID.
Is this long COVID associated clotting pattern also something which patients may encounter in case of a potential side effect of a vaccination, or is it only prevalent within the unvaccinated group?
No, it's unfortunately, clotting pathology is also what we have and others have been noting in vaccine injury. So I must say we have not fully looked at this before. We have looked at a few individuals who we looked at before they were vaccinated and then afterwards, and we traced them, and in the few samples, and now it's under 20 samples that we have looked at, we have seen that when these are healthy individuals that were vaccinated, within 2 weeks or so after the vaccinations, the individuals were significantly hypercoagulable with microclots and platelets activated, and then it slowly returns, and then after 2-3 weeks the clotting pathology returns to normal and the individuals are well again. That is in healthy individuals. But then there's a few individuals who are very sure that they did not have acute COVID to drive clotting pathology, and that developed these clotting pathologies or long COVID-like symptoms. So I must say it's not long COVID. Then you must make a distinction between long COVID from the infection and vaccine injury from getting the vaccine. Some people say that they have got the same type of long COVID-like symptoms. We are very glad to say that we have received funding from our Medical Research Council in South Africa to look at long COVID compared to true vaccine injury, and then also with healthy individuals who are all recovered after they got acute COVID, because as you might know, I think it's very difficult to find anyone that have not been exposed to acute COVID, that have never had acute COVID or not have been vaccinated. So it's very difficult to find good controls, but that's the plan. That is our next step for research, to compare the two pathologies with healthy individuals that might have been recovered from either acute COVID and never had any side symptoms from the vaccine.
I mean, that's a very, I should say, interesting approach, and actually close to human beings. I've spoken last week to an American professor, and he said, first of all, they look at the numbers and at statistics to see if the numbers of long COVID may increase in future or not. And then to see how they deal with it, I say, well, but first of all, don't you give a thought to possible medicaments, how to deal with the situation? So your approach seems to be a very logical one in order to how to find also the adequate therapy for this phenomenon.
Absolutely, and I think we would not be doing many patients a favor if we don't look at it. So obviously, I'm not anti-vax. So it's very important for the global community to be vaccinated. But there might be some instances where there are genetic predisposition for more proneness to various clotting pathologies. And we need to figure this out before we can just have a blanket for everyone. So I think we definitely need to look at that, but we need to have the research to back it up.
You mentioned just now genetic predisposition. Is that this predisposition the same within all ethnic groups worldwide, or is there a sort of prevalence within a certain ethnic group or within certain ethnic groups?
That I will not be able to answer, because obviously we haven't looked at it. But that said, with our research protocol that we have just received ethical clearance, we will be doing genetics, and being in South Africa, we have the wonderful opportunity to look at various ethnic groups. But the main thing that we will be looking at is what are the clotting genetics associated with individuals that develop acute long COVID after acute infection or then after vaccine injury. So it's a very important question that you are asking, and the short answer is we simply don't know yet.
Another aspect of particular interest is the simultaneous presence of persistent anomalous sort of amyloid microclots and pathological fibrinolytic system. So what does it mean, amyloid clots? So for a better understanding, if I may kindly ask you to explain us.
Around about 2014, myself and my good collaborator that I've been working a long time with, Professor Douglas Kell from University of Liverpool, discovered that in the presence of any inflammatory molecule in circulation, and that might be cytokines, it might be LPS, it might be LTA, and those are membrane inflammagens or bacterial wall inflammagens that come from bacteria that are shed by the bacterial wall or membrane, depending on whether it's a gram-positive or gram-negative bacteria. Those molecules, if it's in circulation, can have direct protein-protein interactions with the soluble clotting protein, the main one, fibrinogen. And when these protein-protein interactions happen, the inflammatory molecule, whether it's cytokine or from bacteria, might interact directly with the protein structure. And where it interacts with the protein structure, it lets the protein, the actual protein, uncoil into beta sheets. So just a quick course in biochemistry. Any protein, doesn't matter what protein, have got lots of little alpha coils and then small areas of beta sheets which are uncoiled. So if something binds to the protein, it then can easily untwist the little coils into sheets, and that sheet-like structure then causes the protein to become amyloidogenic. So we coined the term fibrinolytic because it's fibrinogen, which is a clotting protein, interacting with an inflammagen. And as I mentioned, between 2014, 2016, we discovered that the protein, when it interacts with these inflammagens, become amyloidogenic. And we used a well-known marker for amyloid, which has been used numerous times for years before in Alzheimer's brains. It's called theoflavin T. Now that molecule, the fluorescent molecule, only binds to amyloidogenic protein. So we tried that molecule and we found that these areas of disarray in our clotting protein shows up as an amyloidogenic protein, with our marker for amyloidogenic protein, theoflavin T, showing it up under fluorescence. So that's where we started off with the amyloid protein. Now fast forward to COVID and acute COVID, we then used the spike protein, which just for interesting sake, probably last year, beginning of middle last year, two of my collaborators, colleagues, looking at protein structure in Sweden, found that the spike protein itself is an amyloidogenic protein. So spike that causes the disease actually itself can therefore trigger amyloid changes when it interacts with plasma. And just before they published their paper, our paper came out in a journal where we added spike protein, the part of the spike protein that is the more virulent and the one that we believe causes the problems. We added that to healthy blood, and we could indeed induce direct protein-protein interactions with healthy blood plasma samples that looked exactly like what we have found in acute and long COVID. So the amyloidogenic, what are the amyloidogenic nature of the fibrin? It's basically where the spike protein or any other inflammatory molecules that might be in circulation, and during acute COVID and long COVID, there are many, various ones, and people have discussed various interleukins, serum amyloid A, all sorts of molecules upregulated and dysregulated. We have found that when these are present, our fibrin forms these misfolded amyloid structures, and we termed it microclots. Now, interestingly, inside these microclots, we also published a paper where we looked at proteomics. We wanted to see what is actually inside these microclots, and we digested it after quite an effort. And we actually
so it's insoluble.
Yes, and we found trapped inside these clots, we found various molecules that drive inflammation and prevent these clots to break down.
Particularly this, I mean, amyloids, prions are a synonym for amyloid. So there's a whole debate in the history of biochemistry or medicine, and also some conflicts between these who accept the theory of prions or those who go on with the theory of amyloid. If I'm not mistaken, Pusina, he was the one to coin the term of prion because he had this idea of a mechanism which starts just within itself. So Gajdusek, before him, he had rather the idea that there must be a sort of amyloid enhancing factor in order to start this nucleation process. It's like, I understand it like having this two-component glue. So unless you don't have the one component, it will not work. So the way something, maybe this spike might induce this nucleation pattern in order to create this amyloid fibrils, is that a somehow plausible way to explain it in very broad terms to our audience?
Exactly as you said. So it's I think the prion process and hypothesis is exactly what we think is the process. So very small amounts, minute, minuscule amounts of LPS from bacteria can trigger amyloid. So I'm talking about 0.03 nanograms per liter. So if you think about that, it's 1 or 2 molecules in a big swimming pool can trigger amyloid formation, as prions would, the prion hypothesis would suggest. And so yes, so exactly as you said, and the important thing, we believe that the direct protein-protein interactions where the spike protein gets a molecule of spike protein gets exposed to a molecule of fibrinogen can trigger locally these microclots, misfolding proteins, and that is how we think the microclot hypothesis is central to long COVID.
So then the spike would be then the so-called amyloid enhancing factor because of its amyloidic structure?
I think so, yes, that is true. And because of that, then there will be widespread, also obviously the spike interacts with many other cells, but in cells it will interact using a receptor, so it's a lock and key situation where a direct protein-protein interactions, there's no receptor necessary because it it attaches to it and interacts with it, but with the endothelial cells, your vasculature, your platelets, your white blood cells, red blood cells, so the spike obviously is the main driver, but keeping in mind that these individuals have massively dysregulated inflammatory processes with lots of molecules dysregulated, serum amyloid A, von Willebrand factor, because of the damage that the virus molecules shed from the virus, the inflammagens caused to the vasculature and to our immune system. So those interactions all lead to widespread vascular damage that drives and perpetuates microclot formation, because all the molecules released from the vasculature can trigger platelet hyperactivation and in turn trigger microclots. So it's like a circular movement. You cannot therefore also think that you should just address platelet hyperactivation or just microclots. If you just address one and not the other, you don't break the cycle where the one that you don't look at will still be causing vascular damage. So it's a very fine line of what's first and where it happens, but the whole interaction of all the inflammatory molecules with the spike And especially if you think if there's the viral persistence, there's one of the hypotheses that viral persistence allows for the shedding of spike protein, low-grade spike protein shedded. And if that happens, it's just one of the things that perpetuate vascular damage and microclot formation.
So it's not just a cascade as a model, it's a revolving system which permanently perpetuates this pathology.
Absolutely, it totally that. If you look at it, although microclots were our hypothesis, one of the things that happens, that's not the main reason for the disease. The main reason in our hands, in our understanding, is that it is a thrombotic endothelitis. So that is the reason why we have these symptoms. Microclots are just the driving force for the endothelial damage. Yeah. But so if you heal the endothelial layers, then most probably your long COVID symptoms will be better.
And now talking about possible therapies, what would you suggest? We're not recommending any medicine, but is there hope, or how would this better understanding of long COVID help physicians in future to administer the proper medicine?
First, before we get to treatment, we need to do diagnosis. So one cannot, that is a regular, well-known phenomenon. You cannot treat anything if you don't diagnose. So central for long COVID is that we should have widespread diagnostics, and whether that includes, obviously in our hands, we suggest thrombotic type of analysis. And we, as you know, we have looked at the microclots and platelet hyperactivation as key diagnosis for long COVID. As long as you can diagnose that and or together with that vascular damage, that is quite difficult to do. There are a few procedures. There's a brachial occlusion method where you put a tourniquet type thing around the person's arm, and you see how if you constrict it for a few minutes, how the blood vessels react and how healthy they are. There's also instrumentation like an EngoPat, which is an FDA approved instrument that can do it much easier than the more crude brachial occlusion. So there are certain diagnoses that should be in place before treatment. Now, in our scenario in South Africa, I work with clinicians. So this is a disclaimer. I am not a clinician. I'm a laboratory researcher, and I just obtain samples from my clinical collaborators that have been treating patients with various medications. And we have just in fact released a preprint that's under review, where we followed 91 patients throughout the treatment regime, where our clinical collaborator followed a clinician-initiated treatment regime. So why I'm using the word clinician-initiated treatment regime, as you might know, there are no trials yet that have been conducted on triple therapy or anticoagulation or antiplatelet therapy. So it is using medications that are for anticoagulation therapies in this patient population. So therefore, it is a clinician-initiated treatment regime with current medications that are not necessarily formulated and tested for long COVID, but for coagulation in long COVID, pathologies of that. So, so our clinical collaborators have used medication to calm down the platelets and to prevent microclot formation, and that gives the endothelial layers time to heal. And in 91 patients, we had 80% recovery follow-up. We followed them up, and we looked at the microclots and platelets under our microscope. And when they say that they are better after their treatment regime, the microclots and the platelets also were not activated anymore. So the 20% that did not yet recover, because this was just a snapshot, some of them were still on medication. I think about all of them are still on medication, still in the process of recovery. when they say they didn't feel better, and we looked at the microscopy, there were still microclots and platelet hyperactivation. So that said, I think there is also a place for a lot of other types of treatment. So we know there's a Paxlovid trial that Yale is running with my good collaborators, Professor David Petrino and from Mount Sinai, and Professor Akiko Iwasaki from Yale. They're running a Paxlovid trial, and that is an antiviral to see perhaps to treat the viral persistence. So that's the one. And then the other issue that we must also not
throw away. Antiviral medicament.
Yes, it is. Paxlovid, yes.
Yes.
Yeah.
Is it somehow related to suramine?
That I cannot tell you. Unfortunately, I'm not involved there, so I just know that they are testing this. It is a Pfizer product. Then obviously there's the other issue where some patients might develop antibodies or autoantibodies, and that's a total new ballgame. So treatment, if you should, in our minds, you should treat long COVID quite early on and not wait for 2-3 years while a patient's struggling along with long COVID, because at that stage, autoantibodies kick in, and then it's an autoimmune type disease. And when that happens, it is a very difficult thing to treat, as we know with rheumatoid arthritis and all sorts of other type of autoimmune diseases.
But what about the amyloids? Amyloids can't be dissolved even in a laboratory. They are insoluble. Will this amyloid fibrils persist in the body?
No. So your clotting pathology or your clotting process is usually followed up in a healthy individual or disease. It's followed up by a fibrinolytic process. So it's clotting. If clotting happens, fibrinolysis will happen. So the issue with long COVID and the microclots, the clotting breakdown is prevented by these amyloidogenic microclots and molecules entrapped inside it that we have found using proteomics. So eventually your failed fibrinolytic system would break down the clots, but it takes a long time to do that. So the idea is, if one uses anticoagulants, it will stop new clots from forming, and then your body will automatically, on its own time, get rid of the clots that are persisting, and it will just take a very long time, but hopefully new clots don't form, and then you can get a time where your endothelial layers will heal. Now that process can take anything from 3 months to 9 months or more. So
that's why the sooner you start, the better. Don't hesitate. Contact your physician, basically. That's what you're saying, in order to make sure that you receive the best treatment.
Absolutely, and very importantly is, don't do this on your own. Anticoagulation, anti-clotting, and anti-platelet medication can be dangerous, and someone can die because they can be bleeding. It must be a personalized approach where a clinician looks at a patient very, very carefully. Hopefully within the next few months, we will have the first reports of our various trials. So if that happens, then hopefully it will be more, the data will determine how the treatment will proceed.
Professor Pretorius, we now reach the end of this very interesting discussion. Ladies and gentlemen, thanks for having joined us here live on Compass and Quotidiano TV. I'd like to address my many thanks to Professor Pretorius by saying dankie dat u mij uitnodig aanvaard het, en dit was een eer om met u te gesels vandaag. Sterkte met toekomstige navorsing, en ik is zeker dat uw werk zal bijdragen tot die roem van Zuid-Afrikaanse wetenschap. Baie dankie en mijn hartelijke groeten naar Zuid-Afrika.
Baie dankie. Bye-bye.
Bye-bye. Thank you very much.